Good morning, everybody. I hope everyone's well. We're back for another conversation. This is going to be, I think, a game changer, but they all are. We've got Georgi Dinkov back with us this morning, and Alannah is back again. Alannah, I'm going to have to start paying you if you keep coming on the podcast. Okay, guys. Well, thank you for joining me again. Georgie, this started a few days ago with Keith Littlewood and Alannah, and I'm pretty sure Keith is eager to meet you. So maybe that'll happen someday, when all the madness slows down. But what we really started discussing was cancer in the aspect of, I'm sure we all see cancer on the rise now, and there could be many reasons for that. We got Dr. Will Cole, who I mentioned the other day, Alannah, talking about how since the vaccines, as much as nobody wants to hear it, it's out there, are up, they have increased supposedly cancer diagnoses by 3,000% now. And every second day, and I'm only in a small city north of Calgary, locally, I'm getting messages of so and so just got diagnosed or so and so just got diagnosed. And it's a lot, it's scary. And that's why I wanted you guys on because this is an area where the three of you, yourself, Alannah, and Keith, are showing a lot of interest lately in what is driving this? What could we potentially do about it? What is our research showing? Alannah, you've got your book. Keith is primarily focusing on thyroid and cancer. And then Georgie, you've got your research, which is what we want to go into today. So first off, Georgie, before we get into what you've been discovering, what do you think about this increase in cancer? What do you
I,
think is driving it?
well, the vaccines are definitely the mRNA vaccines and even the DNA vaccines are definitely a factor, and not only for cancer. I mean, medicine has now recognized that chronic inflammation, even low grade, is behind almost every chronic disease. And they don't deny. They say yes, chronic inflammation eventually will cause diabetes, heart disease, cancer, Alzheimer's disease, Parkinson, everything. So in fact, the big pharma is now pushing to create a lot of like an entire new class of anti-inflammatory drugs because they tried in the early 2000s with a drug called Vioxx, which is a selective COX inhibitor. It killed quite a few people, so they withdrew it from the market. But now they're trying to reintroduce it and actually produce even more COX and LOX inhibitors, and those are the two main classes of anti-inflammatory drugs in use. So, if inflammation is one of the causes of cancer, why would the mRNA vaccine be a contributing factor? Well, if you remember, almost all of these vaccines have the synthetic version of the spike protein, which was present in the SARS-CoV-2 virus, and that spike protein, its main mechanism of action, so to speak, was to block the angiotensin II converting enzyme. And the angiotensin II converting enzyme takes the angiotensin II protein and converts it back into angiotensin 1. So angiotensin II protein is a highly inflammatory protein and acts on a number of different receptors in the body. And some of the most successful anti-inflammatory and blood pressure drugs on the market are blocking the receptors on which angiotensin II protein acts. But another way to reduce inflammation and reduce blood pressure is to have less of angiotensin II. So there are two ways to do that. First, you either have to block the conversion of angiotensin 1 into angiotensin 2, and there are a number of different drugs on the market that do that. They inhibit this process, and they're called ACE inhibitors, angiotensin converting enzyme. They're some of the most successful and side effect free, should I say? They're not side effect free, but less risk drugs on the market for lowering blood pressure, potentially impacting in a good way chronic kidney disease because high blood pressure usually manifests first there, and also potentially retarding or blocking or even reversing cardiovascular disease. So another way to reduce inflammation is to increase the conversion of angiotensin 2 back into angiotensin 1, and that's what this enzyme called angiotensin 2 converting enzyme does. If you block that enzyme, you're essentially allowing the accumulation of the inflammatory angiotensin 2 protein. And that's exactly what the spike protein in the vaccine does, in almost all of the mRNA vaccines does. So effectively, if you take this vaccine and you have some of that spike protein remaining, then you're probably going to end up with a chronic inflammatory condition, at least in that organ where the mRNA particles have accumulated. And remember, they told us at the beginning that, the mRNA is very unstable. That's why it's encased in nanolipids. That's why it has to be kept deeply frozen, because if it's at ambient temperature, it will very quickly degrade. So they said there's no danger to you. The vaccine is stable just long enough so it can trigger an immune response in your body, and after that the mRNA is gone. Turns out that's not the case. In fact, to this day, they're finding people that got the vaccine back in 2020, or even early 2021, and they're still having mRNA particles from this vaccine. Unfortunately, mostly accumulating in reproductive organs, especially the ovaries in females and testicles in males, but also in liver, kidney. I think they recently did an autopsy, found even accumulation in the heart. So anywhere you have an accumulation of these particles, you're going to trigger a local inflammatory reaction. And then over time, of course, if it's not addressed, then eventually inflammation proceeds to fibrosis, and the final stage of fibrosis is usually cancer. So it's not really a surprise that these vaccines have created like this boom in cancers. There's another situation basically like that we need to consider. Most people over 30 have a diagnosable cancer if subjected to an autopsy. Dr. Pete mentioned this in many articles. So I think it was the 1800s. The Empress of Austria mandated that anybody who dies in a hospital has to undergo an autopsy. And then they found out that every person over 30, if you do a careful enough autopsy, you'll find a localized, already formed tumor. However, most of these are kept dormant, usually by the immune system. But the immune system only works well when inflammation is low. And I know like a lot of doctors will say, well, we need inflammation high in order for the immune system to work. That's not really how it actually works. The immune system's job is actually to clear debris from dysfunctional tissue that is falling apart. It does have other roles as well, such as the attacking the pathogens, but most of the attack on the pathogens happens by generating nitric oxide and hydrogen peroxide. Those are the main kind of like defense molecules that we have against the viruses. The immune system is mostly a sanitation system. So whenever you have high inflammation, the immune system does not work as well. So it may not be able to keep that dormant tumor in check. In addition, multiple studies have demonstrated that if you have a tumor that's in remission, but somehow you trigger an inflammatory reaction, you can reactivate the tumor and go right back into progression. In fact, the tumor may become very aggressive. So if you have a vaccine that's triggering this inflammatory reaction, you can not only reawaken dormant tumors, right? You can make them even more aggressive, and that's why they call them the turbo cancers. People that, let's say, had one of the most benign prostate cancers that are very slowly developing. If you're in your 70s and you get a prostate cancer diagnosis like that, unless it's the very aggressive type, you're most likely going to die of old age before this cancer kills you. But they're finding out that these people that have the slow-growing, relatively benign prostate cancer, after they got vaccinated with the mRNA vaccine, they got the turbo cancer, which is like the grade 9 or 10, which is what they use to grade the aggressiveness. So they either die or they had to undergo surgery and get the entire prostate removed. So they become incontinent, they get erectile dysfunction. So it's a devastating situation, but it applies to almost every other cancer. There are multiple types of cancer. Let's say for liver cancer, they also have several stages in terms of how aggressive the cancer is. So chronic inflammation can not only reactivate the tumor, but it can also make it much more aggressive than it would normally be. And that's exactly what we're seeing around the world. And why would we be seeing? I mean, the reason I think the vaccine contributes. Why would we be seeing turbo cancers, rates increase all over the world, right? If this was a localized situation, such as let's say something happened in, I don't know, the United States or Ireland or some other country, then we will see it only there. But we're not. And the medicine has kind of tried to blame this on the long COVID situation. But then if you look at the countries with a very low uptake of the vaccine, they don't have this increase in the cancers, especially the turbo cancers that we're seeing here. So something about the vaccine is iffy, and I think we have a good idea of what exactly is iffy. And I think more work needs to be done into just how long these particles remain in the body. Because the longer they remain, we have another situation which may be potentially even worse. In other words, there's an enzyme in the body called reverse transcriptase, RNA reverse transcriptase. It can take that spike protein and convert it into a gene and insert it into your genome. So if the spike protein codes for something that causes chronic inflammation, if this thing ends up in your genome, you basically will for the rest of your life, you will be as if you were born with a genetic predisposition for basically chronic inflammatory disorder. Worse than that, you're going to pass it on to your kids. So unless this gene is taken out by some sort of gene editing procedure, then everybody descendant from you will essentially have the gene for chronic inflammation embedded in them. So the longer the mRNA spike protein, the synthetic one from the vaccine, stays in the body, the higher the chance that eventually it will get transcribed back into DNA and get inserted into the genome. So we really need more working to see how long would this mRNA particle stay in the body. And so far, the news is that, well, 3 years later, or I'm sorry, 4 years later now, we're seeing people that got vaccinated in 2021. They still have detectable levels when done by biopsy, not in the bloodstream, of the spike protein from the vaccine still being in them, and that's very bad news. Another bad news is that part of the spike protein contains portion of the protein called syncytin, which is expressed in the placenta, and also portion of that protein is also expressed in the sperm cells. So the longer the spike protein mRNA particle stays inside you, the higher the chance that eventually you're going to trigger some kind of a chronic immune reaction towards that spike protein. And because it contains the syncytin protein and the other protein that's part of the sperm cells, you eventually you're going to get a like a infertility, which is lifelong, and it's caused by this autoimmune reaction. So a woman may be able to beget a child, but she will not be able to carry it to term because the immune system will attack the placenta. And then for the boys, if the autoimmune reaction develops against the sperm cells, they will basically have no viable sperm left. I think it's kind of still early to see how basically to what degree this will manifest, but the situation is already dire. As I mentioned in another podcast with a group called the Strong Sisters, half of young couples cannot beget a child naturally. That's absolutely terrible and abysmal news. In other words, if a couple in the early 20s, there's 50% chance that they'll have to undergo some kind of a fertility treatment, usually for both males and the females, in order for them to beget a child. Now, even if they beget a child, I think I read the statistics, there's about a 25% chance, depending on the health history, that the female will have a spontaneous abortion. So not only is conceiving a child much more difficult, keeping a child to term is now becoming more difficult. And then, of course, we now have all the news saying that what is it? 3 in 10 children are now born with autism. The rates keep rising. A number of different children are born with congenital malformations, with the, various levels of dysfunction of internal organs, and these rates keep rising. So even without the vaccine, we're already in a pretty bad position. Now, I don't think the vaccine is going to do anything to improve on that. I think if anything, it's going to make it worse, especially the fertility portion of that, because even if it doesn't affect the placenta and the sperm cells, if both parents are in a chronic inflammatory condition because of this angiotensin kind of inhibiting situation, the child that they will beget will not be healthy, even if they were able to naturally beget a child. The health of the parents imprints on the child. And there was a study I posted on the Rapid Forum a long time ago, which showed that the epigenetic effects of parents in poor health can manifest for 14 generations later. The good news is that even a single generation of doing the right things, trying to keep inflammation down, eating the right foods, trying to avoid stress as much as possible, can actually reverse those effects. Bad news is it's a very long-lasting effect. So for the people that got the vaccine and continue to live the stressful lives that most of us do, right, and eat suboptimally and are exposed to all kinds of other toxins, it's very bad news. The vaccine did nothing to improve the situation of humanity health-wise. I think it just dramatically worsened it.
How naive of people to think this was just a harmless vaccine to protect granny or granddad.
Yeah.
I mean, it's not only staying in the body in the local sense of time right now. Now we're potentially seeing a ripple effect for generations, which I suppose, Georgie, as you're speaking, you would be in the same situation as me, that we're somewhat grateful that we've already had our kids. We had our kids earlier. Now the concern is for when the time comes that our kids want to have kids. What's that going to look like? Are our grandchildren going to have some disorders that we're going to help carry the burden on? It's a horror story.
Yeah, I mean, if you look at the talks by Dr. Robert Malone, I think he's the one who created the mRNA technology. He's pretty forthcoming in saying that, look, this technology is not new. We had it back in the 70s or 80s. The reason it never made it to the to the general public for general public usage is that it was so dangerous. But all the trials that we did on animals, they were terminated. I mean, they showed toxicity and many of the animals basically died from cancer, even way before they normally develop cancer with aging. Sometimes when you test the mRNA vaccine, you want to see the lifelong effects. So you have a population of mice that will live like a year or two, right? So he said they start, and they almost always at the old age, the rodents die from cancers. But he said when they injected them with the mRNA technology, whatever, it wasn't the COVID vaccine at the time, but some other vaccine, they all started developing cancer at much younger age and dying from it. So if this was known, at the time the vaccine was being developed, I don't know under what circumstances, it would consider a good idea to put something on the market that underwent just a 3-month trial with, I don't know, 500, 600 people, I forget how many. And then the pharmaceutical companies went to the government and asked that the clinical trial data be kept classified. Remember, this is not a national security issue. We're not talking about the military or war plans or whatnot. They went to the court and said, we would like this to be classified for 75 years.
Mhm.
Why would you do that if you're so confident that the product that you developed is perfectly benign? Well, okay, everything has side effects, right? But no other vaccine has been requested to be classified for 75 years. I mean, only one reason, you're afraid that whatever's in those results is going to spur public outcry, and it did. Unfortunately, the public has a short memory span. It kind of forgot about it. And one of the things that the declassified data showed about the Pfizer vaccine was that I think the majority of the women who were pregnant and got the vaccine, they did not carry to term. Yeah. So that alone should tell you something, because spontaneous abortion is usually a very good indication that something in either the mother's health or her surroundings or whatever she's intaking is not good for her. And the one thing that changed between the active group and the control group is that the active group got the vaccine. The control group did not have these miscarriages. Isn't that a pretty obvious situation that on this
It's
point
pretty
alone,
obvious
a
to
vaccine should not
those.
have been introduced, at
It's
least to
pretty
me.
obvious to us with our eyes open. And you said you don't know under what circumstances they'd put this request in for. I think we do know the circumstances. Like it wasn't for
Yeah,
our own good. It was
of
something
course.
nefarious at
Yeah,
hand
yeah,
there.
yeah,
Yeah, it's interesting because my mom treats cancer every day, and it's pretty much standard for her now to ask, like, did you get the vaccine? Because it's kind of like, is it grow, it kind of is an indicator. Now she always tests D dimer because she's seeing everyone having elevated D dimer, which is an indication your blood's clotting. So she's even changed, kind of the standards of how she treats cancer because of the vaccine. And
Yeah.
she's seeing it, way more like turbo cancers at her clinic and stuff. It's crazy.
So I
yeah.
don't want to keep harping on about the vaccine because I'm sure people have already turned off. Nobody likes it to hear.
Oh, one good news about this. I just read this on the news like a couple of days ago, that a court, I think in Louisiana, said that the vaccine companies can be sued by parents whose children have been vaccinated without consent. And we know that happened. In fact,
Mm,
around the pandemic, I was really scared of sending my kids to school
mm,
because DC passed this draconian law, which they've since revoked, but it was active at the time. The children 10 or older can decide on their own
uh,
whether they want to have the vaccine or not. And then, and worse than that, they also passed a law which said that if the child is somehow coaxed by the school administrators to get vaccinated, the school and the insurance company and whoever administers the vaccine are under orders of secrecy. They're banned from sharing this with the parents, so you won't even know. In fact, they ordered the insurance companies to keep 2 sets of records to conceal the fact that the child is being vaccinated against the wishes of the parents. And that portion, I think, finally found its way through the courts, and now a federal judge in Louisiana has said the parents of, at least in Louisiana, the parents of children who have been vaccinated with the COVID-19 vaccine, whether mRNA or the DNA one, without consent, they can sue the pharmaceutical companies for damages. And I think the people who brought the lawsuit is way more than 20, so that's already enough for a class action lawsuit. So even though you cannot sue directly, like you and I, if we were to get vaccinated with consent, we cannot sue the vaccine companies. Maybe they'll get like through a roundabout way, they will get a massive class action lawsuit
mm.
and see what happens. My concern is that even if somehow you're able to pin the vaccine companies, the pharma companies, and make them pay a lot of money, because they're now considered companies of national security importance, they'll simply get bailed out. So we the taxpayers will basically cover the cost if they end up paying, which it's a very low chance they will. But if they do, yeah, the parents will get something, right, in terms of money. But guess what? We will be paying the parents, not the pharma companies.
The whole system's corrupt, isn't it?
Yeah. Yep. 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 Yep.
So not last week, on Tuesday, Alannah and myself and Keith spent we spent a good portion of time discussing stress as a factor for cancer, but not just the emotional stresses, but also the influence that has on the hormonal system. Do you want to add in your little bit of input there?
Yes, quite a bit of input. So in medicine, the glucocorticoids are considered the gold standard for treating like an acute inflammatory situation, especially for autoimmune conditions. If somebody comes in with rheumatoid arthritis, the joints are swollen, they can't move, they get an injection of dexamethasone or like some other synthetic glucocorticoid, which is just a hormone that mimics the effects of cortisol that we endogenously produce. So yes, cortisol does have direct anti-inflammatory effects, but very little known fact is, and I discovered only in the last year or two, is that cortisol actually upregulates the expression of the three most important inflammation mediators in the body. It increases the expression of the cyclooxygenase protein, which produces prostaglandins. It increases the expression of lipoxygenase protein, which produces leukotrienes, and it also increases the expression of the so-called TLR4 protein, which is the main protein through which endotoxin exerts its inflammatory effects. The combination of prostaglandins, leukotrienes, and endotoxin are probably responsible for more than 90% of the chronic inflammatory reactions that we have in the body. And I mentioned earlier, big pharma is very focused on creating COX and LOX inhibitors as basically treating a number of different chronic inflammatory conditions. So while cortisol is maybe good for you in the short run, it really sets up the stage for a massive rebound on inflammation as soon as cortisol is gone. Right. So really, when you're treating people with synthetic cortisol equivalents such as dexamethasone or betamethasone, I think is another one, whatever, or hydrocortisone, yes, they will probably improve like immediately over the next couple of days. The moment you stop that treatment, the rebound inflammation will be much worse than what it was before. So when we're under chronic stress, while we're under chronic stress, I guess we don't feel the effects of cortisol, the havoc that it's wreaking on their bodies. But eventually, when stress subsides, thankfully, because it can actually kill us if it continues for too long. Eventually, when stress subsides, now we're into inflammatory state, and we already mentioned earlier the chronic inflammation is now admitted even by mainstream medicine to be one of the main causes of cancer. So it can cause cancer de novo. If you already have a tumor, which is apparently is true for everybody over the age of 30, then the inflammation will reactivate it. Well, guess what? Whenever you're under stress, you're kind of setting up the stage for that thing to happen as soon as the stress subsides and cortisol disappears. But even while cortisol is high, it has a number of different very bad effects on the metabolic chain, which the bioenergetic theory and Dr. Pete's work and mine say is really crucial for the development of cancer. In other words, cancer is a metabolic disease, and the reason the way cortisol affects the system is that it inhibits the oxidation of glucose. It increases lipolysis because it also raises the production of adrenaline. It increases lipolysis, so you're going to flood the bloodstream with free fatty acids that are coming from your fatty tissue. And as we know from the rando cycle, whenever there is an oversupply of either glucose or fatty acids, it inhibits the oxidation of the other. So if cortisol directly inhibits the oxidation of glucose and then increases the supply of free fatty acids in the blood, then it's going to inhibit this excess of fatty acids will inhibit the oxidation of glucose even more. So it will put and whenever you over-oxidize fatty acids, you end up in something called a reductive stress. Why? Because the oxidation of fatty acids consumes one of the cofactors required for the oxidation of fatty acids. It's called flavin adenine dinucleotide, FAD, and it's the crucial cofactor for the function of the so-called electron transport chain complex 2. So basically, when you over-oxidize fatty acids, you're going to block electron transport chain complex number 2. Whenever you have a block in the movement of electrons from food to oxygen, which is what happens when you block, let's say, electron transport chain complex 2, you're going to have a buildup of electrons. And the buildup of electrons causes something called oxidative stress. It's not really oxidative stress, it's actually reductive stress because you have a buildup of electrons, they're not meeting oxygen. And then this is going to create all kinds of problems. First, it's going to increase the lipid peroxidation of the polyunsaturated fats in our tissues. Second, multiple studies have demonstrated that whenever you have so-called reductive stress, in other words, not enough oxidation, the cell starts to dismantle the machinery for oxidative phosphorylation. Apparently, the cell decides that it doesn't need it, right? And nobody knows how long it takes, but it's known for a fact that in vitro, if you do this consistently for several generations of the cell line that they're using, eventually you're going to start having cells that are completely lacking the machinery for oxidative phosphorylation. In other words, these cells will only be able to conduct glycolysis, which is the cancer metabolism. So what I'm really trying to say is that when you're under chronic stress, whether severe or mild, over time you send the signals to your cells that you're under stress and that you cannot really produce energy the normal way, the healthier, which is through oxidation, also called oxidative phosphorylation. So the cells over time, because keeping that machinery takes energy, the cells will simply become more effective and say, why am I keeping this energetic, expensive machinery in the form of all these proteins involved in oxidative phosphorylation? I'm going to get rid of it and start producing energy the dirty, cheap way, which is glycolysis. So really, glycolysis is like the coal plant, while the oxidative phosphorylation is like I don't want to say nuclear plant because there's a bad connotation, but in terms of efficiency, that's really the comparison. So the cell will go back to coal burning, which creates a lot of bad byproducts. It really doesn't produce that much energy compared to per unit of raw material used compared to, let's say, the nuclear power plant, putting radiation aside, completely in terms of efficiency. And that's really cancer. The cancer metabolism is that excessive glycolysis, overproduction of lactic acid, and then really lack of complete oxidation of glucose to carbon dioxide and water, which is what happens when you're using oxygen properly. Combined with that, we're also seeing in cancer patients insulin resistance, which should immediately kind of like, if there's an endocrine doctor there, he or she should immediately think, okay, there's an oversupply of fatty acids, because we now know that it's the fatty acids that are causing the insulin resistance. It's not the sugar. Yes, the sugar is being wasted. And because the sugar is wasted in the cancer cells increase their uptake of sugar to compensate for the perceived lack of it because they don't oxidize it properly. So a common test for cancer is that to inject radioactive glucose solution into a patient and then put them in a PT scan and then see which part of the body starts to light up, because that means that part is really uptaking a lot more glucose than the rest. And because the glucose is radioactive, they can pinpoint it. That usually means there's a tumor there. But that's not because the tumor is addicted to sugar. It's just that the cells in the tumor perceive lack of glucose, and they increase the expression of the so-called glucose transporters, GLUT, and that's why they can uptake more glucose inside. But it's not because they're addicted to it. If you look at those cells and what they produce in terms of metabolites, you will see excessive fatty acid oxidation. You will see a deficiency of FAD plus, flavin adenine dinucleotide, and you will see a strongly reduced mitochondrial ratio of NAD plus to NADH, which of course, whenever that ratio is low, it blocks the oxidation of glucose. So the cancer cell uptakes a lot of glucose, but is prevented from oxidizing it simply due to the Rendell cycle. And I've spoken to a lot of oncologists. They say, well, no, there's genetic mutations. We still don't know if the mutations causing the metabolic disturbance or it's the other way around. And I recently I was reading an article. There's an enzyme in the body called poly ADP ribose polymerase, PARP1. There are multiple families, but PARP1 is the main one. And the main function of the enzyme is to repair genomic instability. If there's a damage in the genome somewhere, that enzyme depends very heavily on the availability of NAD plus, right? So in other words, if the cancer cell is in a state of reduction, it has deficiency of NAD plus, the enzyme PARP1 will not be able to work. So it's natural to expect genomic damage and instability in a cancer cell, but it's a result of the metabolic deficiency, right? So this is direct evidence. And one of the most successful recent drugs on the market is a PARP1 inhibitor. And what it does is when you inhibit PARP1, you allow the cell to kind of recover a little bit its levels of NAD plus. But I think there are better ways. You don't want to inhibit PARP1 because you do want the genome to be repaired. Can we increase NAD plus through other means? And the answer is yes. Number one, provide a precursor such as niacinamide or niacin or nicotinamide mononucleotide or nicotinamide riboside, I think. Any of these is a precursor to NAD plus. And the second way to increase it is simply oxidize NADH back into NAD plus. But that's what normal oxidative metabolism does. So really another indication that really the reason a cell is under reductive stress is because it's not properly metabolizing glucose. There's no sufficient oxidative phosphorylation. So we have a lot of NADH and very little NAD plus. So really that's all a cancer cell is. And of course the hypothesis can be formed is, okay, how can we prove that it's the metabolic defects driving the cancer and not the genomic ones? I said, okay, let's do experiments and see what happens if we raise NAD plus, right? If we remove the block, or at least try to stimulate the oxidation of glucose, and inhibit the excessive oxidation of fatty acids, and what happens when you also try to reduce inflammation. So can we do all of these things together? And the answer is yes. There are a number of different over-the-counter compounds that play very vital role into the oxidation of glucose and, of course, lowering inflammation. Vitamin B1, also known as thiamine, in its active form, which is called tyramine pyrophosphate, is the required cofactor, the main cofactor for an enzyme called pyruvate dehydrogenase. Pyruvate dehydrogenase is the rate limiting step for oxidizing glucose, and it's known to be blocked in cancer. Back in 2013 or 14, there were big news coming out of Canada, I think University of Toronto, where they were using a drug called dichloroacetate to actually treat a number of different cancers, and the results were spectacular. So what does dichloroacetate do? Very simple. It simply activates pyruvate dehydrogenase. Unfortunately, because of the chlorine molecules inside, the molecule is toxic when used chronically. But the results are spectacular. The university said, "Give us money. We want to test it more." There was no interest. Of course, there's no interest. It's unpatentable, and no, you cannot make money out of it. But it actually proved, it was a proof of concept that activating pyruvate dehydrogenase is therapeutic. Well, another way to activate pyruvate dehydrogenase therapeutically without toxicity is providing vitamin B1. It's one of the cofactors for pyruvate dehydrogenase. Another way to activate a separate way, in other words, synergistic, is to also increase the ratio of NAD plus to NADH. That's what niacinamide does. I mean, when you give somebody a precursor to NAD plus. So I said, okay, let's do a clinical an experiment with mice, right? Let's take a highly lethal tumor that is known case of spontaneous regression or remission or successful treatment by any established drug. And that was, in my case, was the so-called JEKO-1 line. It's a mantle cell lymphoma, and it was the deadliest cancer model. It's a human tumor, by the way. It's the deadliest cancer that the lab had. So what they did is take the tumor, create mice that lack immune system, and then they transplant the tumor on them, and it's called a xenograft model. So I started doing experiments. First, I started with the vitamin B1 by itself. There was a little bit of effect, like compared to the non-treated animals, where tumor growth curve was exponential. They die within 14 days, 11 to 14 days. So with the timing, they live to about 25 days. So I said, okay, still exponential curve, but flattened, right?
Yeah.
Said, okay, so there's a suggestion this may work. Now let's add niacinamide to the thiamine. Why? Because niacinamide is not only a precursor to NAD+, so it's going to help the thiamine oxidize glucose, but niacinamide also inhibits lipolysis. And we know that lipolysis is high in cancer patients. They have an oversupply of fatty acids. As I mentioned earlier, they oxidize primarily fatty acids, the tumor at least, and they insulin resistant. So okay, so so niacinamide has two roles here. First, it increases NAD+. Second, it inhibits excessive lipolysis. So I did a second experiment, vitamin B1 and B3. Really good results, encouraging. Again, control group exponential growth. Thiamine and B1 flat for about 30 days, and then it started growing again. But at least I stopped the tumor growth initially, completely stopped. Then I said, okay, what else can we do? Well, let's say if pyruvate dehydrogenase is really, really blocked because there's a tremendous oxidation of fatty acids. So it's, the B1 and B3 by itself are not sufficient to activate it. Well, there's a kind of like a bypass you can do. Whenever you have pyruvate, it has to get into the Krebs cycle in order to get properly oxidized. So if PDH, which is the main gateway to it, is completely blocked, what else can we do with pyruvate? Well, there's another enzyme called pyruvate decarboxylase, the main cofactor for which is biotin, which is vitamin B7. So if you have a buildup of pyruvate, you cannot go through pyruvate dehydrogenase. Maybe you can go through this other enzyme and still enter the Krebs cycle. Now, by the way, no matter which one of the steps of the Krebs cycle you enter, that's as good if you enter through pyruvate dehydrogenase. Basically, that's why it's called a cycle. Any of the intermediate metabolites in it are basically going to stimulate the rest of the cycle and then continue on to the end of the oxidative phosphorylation. So why did I choose biotin? Well, I've been looking at biotin starting back in 2014, and it was a very interesting study stating that the addition of pharmacological doses of biotin concentrations to cells triple their production of carbon dioxide, which can only happen if biotin stimulates the function of the Krebs cycle, which theory says it should because it's a cofactor for one of the enzymes that enter into it. And then there was a really remarkable study with patients with primary progressive multiple sclerosis, about 30 of them, and they gave them really high doses of biotin, 300 milligrams daily. For comparison, the daily requirement, I think, is like only about a milligram or maybe even less. So those were pharmacological doses of biotin. So these patients went into remission. And primary progressive multiple sclerosis is not known to go into remission. That's why it's called progressive. It just keeps getting worse. And when they looked at the metabolic profile of those patients, they saw that their carbon dioxide production had increased, the production of lactate had decreased, right? And the level of free fatty acids and triglycerides in the blood was lower. So this means these patients started oxidizing more glucose, less fat, and their lipolysis levels were lower. I said, excellent, let's try biotin. So I added that to the B1 and B3. So I added biotin, which is B7, and I added at a slightly lower dose than what was used in humans. In humans, they used 300 milligrams daily. The dosage that I basically used, the equivalent for mice converted to humans would be about 150 to 200 milligrams daily. And then I added the biotin. So with the three vitamins, the tumor growth was completely stopped. So no matter how long we kept the mice alive, they did not die. The tumor did not disappear, but also did not grow. So that combination alone achieved, I would call, full remission, right? Tumor's still there, but it's dormant, right? So I said, okay, so far so good. What else can we do? And then, of course, for people that are familiar with Dr. Pete's work, he's mentioned aspirin in probably every single article of his, and how I think he's told multiple people that high doses of aspirin, in his opinion, can probably cure cancer. And the main mechanism through which most people are familiar with aspirin is that it's an anti-inflammatory drug. It's a inhibitor of the cyclooxygenase enzyme. In other words, it inhibits the production of prostaglandins, and it's known that inhibiting the production of prostaglandins helps in cancer. In fact, there are several tumor studies, cancer studies with humans where they got the main cancer therapy, but then another group got also the main cancer therapy plus aspirin, and those people survived for much longer, and some even went into remission and the tumor did not reactivate. Of course, they will never do an aspirin only group because it's considered unethical. Why? Well, they say if a specific cancer has a standard of care treatment approved for it, we cannot have a control group because it's unethical. We're killing these people by testing, by giving them only aspirin. But that's what I do with the mice. So then I added aspirin to the vitamin B1, B3, and B7, and the human equivalent dose of the aspirin that I gave to the mice is about 13 milligrams per kilogram of body weight. So that means between 1 and 1.2 grams of aspirin daily, which sounds high, right? But multiple human studies have been done with it. And in fact, back in the day when there was no synthetic cortisol to treat conditions like rheumatoid arthritis, the only treatment available was actually aspirin. And the standard treatment for rheumatoid arthritis is 8 to 10 grams of aspirin daily. Really an absolutely massive dose.
That's
So
huge.
mine 1 gram to 1.2 pales in comparison. But I got a lot of criticism on Twitter and over email saying like, that's a really massive dose. This will never be allowed clinically. Why would you use it? It's so dangerous. Then I started providing studies with patients with Crohn's disease, multiple sclerosis, cardiovascular disease, and they were actually given 4 aspirin tablets daily. Each tablet is 325 milligrams. That's right about 1.2, 1.3 grams, which is what they gave to the mice. And there was no side effects. So and I consider that like a super physiological, but not really pharmacological dose of aspirin like the one for rheumatoid arthritis. So as soon as I added the aspirin, I did another. So mind you, each one of these separate experiments. First, all the one with only B1, vitamin B1, then one with only vitamin B3, then one with only biotin, vitamin B7. Then started combining 2 of them. Then started combining 3 of them. And when the 3 of them stopped the tumor growth, I said, let's add aspirin to it. And as soon as I added the aspirin, and I posted this study on Twitter about a year ago. There were 3 mice, and then all 3 had the tumor completely disappear. There was initial growth, but over time we had basically the tumor shrank to baseline, and then even the scar tissue disappeared. And the reason the scar tissue is that when they take the mice that have been immunocompromised, they do a little incision in the skin, and that's where they inject the tumor cells, and then they stitch it up. So it forms a little bit of a scar, right? The scar tissue there. But with continued treatment, not only the tumor completely disappear, even the scar tissue disappeared. And then I asked the lab to keep the mice alive and stop the treatment because, as you well know, in human trials, like when you go to, let's say you go to a doctor, you have a tumor, they cut it out with surgery, and then you ask, am I cured? They said, no, you're in remission. and we can only declare you cured if you stay in remission for 5 years or more.
Mhm.
So I said, let's see what happens to the mice when we stop the treatment. Is the tumor going to recur? It did not. So we had a full cure of a tumor, human tumor, though transplanted on mice. That I don't know of any other study, published or unpublished, that basically has achieved even remission, let alone cure. And then there was a human mantle cell lymphoma, and since then I started doing some other experiments, and I sent Chemaines two of my ongoing studies, one with breast cancer and another one with prostate cancer. And the breast cancer one is using the same combination, the B vitamins plus aspirin, and there is another compound that I'm using also as a separate group. It's a metabolite of aspirin. It's known as 2,6-dihydroxybenzoic acid. Why am I using that? Well, I was speaking to Dr. Pete once on one of the Danny Roddy shows, and I don't think it was recorded, but I said, okay, is there anything that can be done to increase the effectiveness of aspirin for cancer? He said, well, because cancer is basically a state of extreme reduction, anything you can do to dramatically increase oxidation, which really means acidity, or make the molecule more lipophilic than aspirin, should actually increase its effects. In other words, produce more effects at the same doses or even lower doses. So I started researching for more lipophilic, more acidic analogs of aspirin. And just by looking at all the different metabolites of aspirin, I discovered that this one metabolite, 2,6-dihydroxybenzoic acid, is about 10 times more lipophilic and 10 times more acidic than aspirin. So I said, let me see what this molecule can do. And I found a remarkable study with rheumatoid arthritis from back in the 1950s, I think. So they gave people with rheumatoid arthritis either 7 grams of aspirin, right, which is like I mentioned earlier, 8 to 10 grams of aspirin is the standard treatment, or a dose of the 2,6-dihydroxybenzoic acid that was 10 times lower. In other words, 700 milligrams. The people given the 2,6-dihydroxybenzoic acid had a complete disappearance of the rheumatoid arthritis, severe rheumatoid, within 24 hours. So I said, okay, we got a candidate. So I started using that as one of the groups, separate groups, not added to the B vitamins and aspirin, but just to test effectiveness. And if you look at the top right corner, you will see that the green, actually all curves are already showing inflection. In other words, the tumor growth has already been stopped, and now it's starting to regress. So we'll see if it disappears, but that's what we have currently for breast cancer. And there are 3 groups. One is with the B vitamins and aspirin. One is with the 2,6-dihydroxybenzoic acid, and I think one is with progesterone. So those are the 3 groups that I currently have. And so far, it looks like the B vitamins plus aspirin or the 2,6-dihydroxybenzoic acid are doing best.
This is the second one you shared with me as well.
Yes, and this is a really good study because it strikes at the core of one of the, in my opinion, the most nefarious hypotheses in medicine, which is that prostate cancer is caused by androgens. And in addition, they also claim that it can be treated by estrogens. Now, if you look at people who have prostate cancer, you immediately realize that these people are not exactly highly virile men pumped full of testosterone. They're 60 plus usually, right? They have a beer gut. No judgment being passed here. Just saying that they're the exact opposite of the phenotype of the high testosterone virile male. So if the really androgens were causing prostate cancer, we should be having males in their 20s, coming down with prostate cancer left and right. We don't have that. In fact, there was a recent study with a very limited one, I think only 6 or 7 patients, that had terminal prostate cancer. And I don't know why the doctors decided to inject their prostates with testosterone. All of these patients were cured. For some reason, this study did not really attract, not some reason, I think we know what the reason is, because it directly invalidates the hypothesis that androgens are causing the prostate cancer. But it was a really remarkable study. But more importantly, the theory says that it's not all androgens that cause prostate cancer. It's particularly one specific androgen, which is the strongest androgen in the body, also known as dihydrotestosterone or DHT. Just a cursory glance at the literature and the experiments done initially with prostate cancer in the early 20th century, and then how it progressed, it immediately shows you that at best this theory is incompetence, and at worst it's malicious destruction of males. So I said, how can we disprove it? Well, let's have mice with human prostate cancer, and let's treat them with dihydrotestosterone. And as you can see, I have multiple groups there. And in addition, in order to make the claim stronger, I said, okay, not only are we going to give them an androgen, but we're also going to give them an anti-estrogen. and in this case, it's an aromatase inhibitor. So there are multiple groups, as you can see in that study, but the group getting DHT plus the aromatase inhibitor already has a tumor volume of 0. Not only the tumor never grew from the very start after it was being implanted, it directly started diminishing. And now I think you have 2 or 3 animals that are already cured. And the two groups that are which we have full cures are, one group has the androgen DHT plus the aromatase inhibitor exemestane. In other words, an androgen plus an anti-estrogen. And the other group has progesterone and also exemestane. So in other words, an anti-estrogen and an aromatase inhibitor, which is another version of an anti-estrogen. So I think combine this together shows that androgens are not the cause of prostate cancer. In fact, they're probably the cure for it. And the patients getting castrated physically and chemically, usually by given estrogens and some other even more nefarious drugs, are actually being butchered. I don't see how else this can be phrased. They should not have their androgens being decreased. To the opposite, to the contrary, they should be increased. So yeah, I think it's the reason I think it's one of the most nefarious things is because there's been a war lately over the last 20 years on the so-called toxic masculinity. And there's a lot to be said about toxic males. Don't get me wrong. A male can certainly be overly masculine. It can be abrasive, they can be rude, they can be violent sometimes. But even for those cases, if you look at it, they're not usually high androgens. They're actually high androgens and estrogens. So it's really estrogens driving a lot of this so-called toxic masculine behavior. High testosterone males are very calm, assertive, they're open-minded. They know what they want, but they don't impose it on others. So, but even on those types, basically, the common culture is that there's nothing good that's coming from males. We kind of have to rid of them. I've been hearing this a lot online, especially on like social media. And I think this theory that cancer is being caused by androgens, prostate cancer at least, it's kind of like it's really like it's being used. I've heard many doctors say, well, one good indication that androgens are really not good for anybody, especially for males, is that they cause prostate cancer. And another one is that they cause cardiovascular disease. And another one is that they cause violence and criminality and whatnot. And all of these things, if you start looking at them, it usually turns out to be the exact opposite. I mean, we've been seeing a decline of sperm counts since the 70s. The average testosterone levels in males have fallen by more than 50% since the 70s. So if anything, yes, we are seeing more violence, more antisocial behavior, more criminality and whatnot, but the estrogen levels have been declining. So this combined with my experiments really shows that we don't want that. We want the opposite. We want the high androgen males, the real male phenotype, not the aggressive homicidal warrior that they try to present on TV. That's not a high androgen male. That's usually a high androgen and high cortisol or high androgen and high estrogen male. But if you really get the classic high androgen, low cortisol, low estrogen male, you get kind of like the fatherly figure. The person is there to protect, to build, to enhance, right? To sustain, not to destroy, or fight with others. That's something that the social media has been pushing. But in any event, my interest is mostly in health, and I think if we can get rid of the fact of the idea that androgens are bad for prostate cancer, it's a very short stop from there to showing that estrogen, if it's causing prostate cancer, as it kind of obvious in this case, what other cancers can estrogen be causing? Now, the previous screenshot that you showed was breast cancer. It's an estrogen receptor positive kind of breast cancer. So we know that if we inhibit estrogen in that model, we should expect good results. But one of the other models that I'm currently testing is the so-called triple negative breast cancer. And the results that I have there so far, even though medicine says this tumor is immune to hormonal manipulation, it has no receptors for steroids, right? So it really does not, it's not amenable to any hormonal treatment, also turns out to be wrong. Estrogen in that model promotes the growth, progesterone and aromatase inhibitors and even androgens are actually therapeutic. So double lie here. Number one, that estrogen is good, and number two, that there are tumors that are not endocrine. That in other words, if you mess with the steroids, you're not going to achieve any therapeutic result. So for that triple negative breast cancer, I already have preliminary evidence that is also not true. So two major lies here that are being exposed. One, that androgens cause prostate cancer, and or that estrogen is therapeutic. And the second one is that triple negative breast cancer, estrogen plays no role there, and in fact, no other hormone plays any role there. Also a lie, double lie. One, estrogen definitely plays a role because it's promoting the growth, at least in my experiments. And two, that the that the tumor is certainly amenable to hormonal manipulation, especially if you give something like progesterone.
Georgie, you must be the most popular guy in the room when you go to events speaking like this, because this is not what mainstream is saying at all.
I think you're being facetious. I'm definitely not the most popular guy when I walk into a room. I often get kicked out
Or not invited.
or not invited or being accused of being negative Nelly or Debbie Downer, and it's saying like, Georgie, we came here to drink, stop with your conspiracy theories, like stop telling us or showing us that pharma wants to kill us all. I'm like, well, do you want to die? I mean, like, you asked me the question, I answer. If you don't like the topic, then we should stick to, I don't know, sports or beer or whatever.
Yeah, but even they can kill you as well. So.
Yeah, 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 yeah. So I usually try to stay away from these topics. Even when people ask me now these days, I kind of look at the person who is asking me, and if I think that a person is either not being, genuine in terms of asking for my opinion, or that if I say certain things that the person it will not contribute to their general well-being, I usually change the topic. It's not worth it. I mean, I post things online for the people that are ready to read and see and experiment for themselves. I got a number of emails from people saying, "Hey, let's publish these studies. Let's take on big pharma. Let's do this." I don't want that. This is a multi-hundred-billion-dollar business. So my
Mm.
goal is not to publish because they will immediately attack the study and probably get it like retracted. I think we remember how many studies got retracted during COVID, and some of these studies were published by very well respected and renowned researchers. I think it was there was a researcher at the Stanford called Dr. Ioannidis, and he was the one who published the original studies that showed that 75% of all scientific findings are false, and
Oh yeah.
50% of all randomized placebo-controlled clinical trials are also false. And then during the early days of COVID, he was saying we should not be locking down, we should not be vaccinating because during a pandemic you do not vaccinate, you're only going to increase the fitness of the virus and it's going to start to mutate, and the vaccine will be worthless, but also you're going to have a much worse virus than before. So I think the two studies he published in the middle of 2020 about the incidence fatality rate, about the lockdowns and the vaccines, they all got retracted. And he's not just a nobody. He's an endowed professor at the Stanford University Medical School. So if they can retract his studies, imagine what will happen to mine. But worse than that, I mean, like I think this information is so disruptive potentially that it's I don't want to say it's not for everybody, but it's only for the people that have kind of like exhausted other options, people that are ready to change their mind on things. If somebody believes in the medical system, I don't want to cause discomfort or disharmony by saying, it's not going to work, it's going to kill you. That alone can actually trigger a nocebo infection, so-called, which is the opposite of placebo infection, and this person can get worse, much worse than if they were only getting the standard treatment. So if they ask me if I gauge that the person is genuine in their interest and that they may benefit from the information, then I'll speak on the topic. If not, then I'm posting things on the blog and Twitter. Whoever wants to see it will see it, and that's it. That's how it has to spread. Grassroots. This is the only way to really spread it without getting too much into the crosshairs of big pharma, because they have a tremendous amount of power and they can stop this out. Unless it's like really already like a prairie fire, if it's like too big to actually suppress.
Oh, they could totally destroy your life.
Oh,
And
absolutely, yeah,
unfortunately, some people are already a lost cause. They
yeah.
they don't want to know. And Alannah, this is what you had mentioned the other day, was a lot of the medical and health industry at this stage is just symbolic. It doesn't mean a lot.
Yeah, I mean, everything's backwards at this point, in the healthcare industry. So,
Yeah,
Yeah.
uh,
there's a blog. I forgot a guy who's. I think he was following Ray PT2. He has a blog called 180-degree Health, and he's basically saying if you blindly do the opposite of what the doctor tells you, on average, you'll probably be about 90% right.
yeah,
uh, So better
everything.
probably don't go to the doctor for anything other than really emergency. But on average, whatever the doctor recommends, it's probably going to be, even if the doctor is a good person, they don't have much latitude. They can lose their license, they can get sued
Totally.
from a practice, right? So they're really compelled to tell the story that the American Medical Association, heavily sponsored by Big Pharma, is telling the doctors to tell.
Yeah, the standard of care. People don't even realize how rigid it is. Like there's literally a book that like my mom has that's like this is how much chemo to give this person. It's down to like very specific, guidelines that you have to follow. And they face legal risks, and the hospital, face risks too. It's not just them. But and then, also, I actually, one thing we write in the book is we blame doctors and stuff, but oftentimes I've heard doctors be actually hesitant on some of the treatments now. But the patient doesn't have any other options.
Yeah.
And so doing something is better than doing nothing, even if it's not going to help them. So our psyche too buys into it. And so it's like, it's actually, when you're in a fearful place, you're scared. You don't know what to do.
There's a great play by George Bernard Shaw. I don't think it's a play, but it's like I think it's an essay. It's called on doctors or on medicine, and he really, it's like what we're discussing right now. He knew it 100 years ago, and there's a line which says that until an alternative to medicine is found, the truth about the doctor and medicine is so scary that the vast majority of us dare not think about it. So when you're in a dire situation, he's speaking about the exact same thing. Medicine is biased in favor of action versus
Right.
inaction, and even the relatives basically are sitting there. It's like, okay, if the person is dying there, I'm much more likely to acquiesce to or agree to a treatment, even though the treatment is very dangerous and may very well kill them, because you don't want to be seen as somebody doing something while your loved one is suffering. And I think
Mm.
medicine is also in a similar situation because they can be sued if the relative says, you sat there and did nothing while my loved one was dying.
100%. You get sued if you don't do it. Like, don't take action.
Yeah.
Not if
Much
something.
more often than if you
Yeah,
do it than if you do take action.
exactly. Exactly.
With
So,
many people, you will hear it a lot now in mainstream, especially in like Facebook groups and on Instagram, like doctors are no help. They don't want to help us. My doctor will do nothing. And I don't think it's inadvertently that all doctors are bad people. They don't want to help you. It's that their hands are tied. They're stuck between a rock and a hard place of potentially losing their livelihood as well. So they're only allowed to do what we've just mentioned, the bare minimum that potentially won't help you at all, but they have to follow the guidebook.
When I first came to the States, it was in '97. So I decided to study computer science. And I walked into a classroom, and the professor was from I think Sri Lanka, and then we quickly realized that me and the professor were the only two foreigners in the room. So after the class, he kind of called me. He said, "Listen, I need to talk to you. Come over here." He said, "Listen, both you and I are foreigners. Let me tell you how things work in this country. The only two professions in this country that do well from hired labor are doctors and lawyers. It's like, think very careful if you want to do computer science, because I cannot guarantee that you will do well as a foreigner in this country." So I ended up doing computer science, and I saw him like in shortly after the pandemic. I went on campus for some other reason, and he recognized me. He called me over, "Georgie, come over." He's like, "Remember what I told you when we first met, that only doctors and lawyers do well in this country?" I said, "Yes." He's like, "I changed my mind. Even they don't do well. In fact, they've become the worst professions that one can go in currently." I said, "Why?" He's like, apparently his family went through health troubles and legal troubles, and he got so disgusted with the medical and the legal system. He said both are irrevocably corrupt. And he says, like, whatever you do, not only don't practice because you already have a computer science degree, but stay away from these people, because not only they're not going to help you, some of them will actively try to harm you if they can determine they can make money off of you.
mm,
So yeah, so it's no longer, these two professions are no longer. I don't think lawyers were ever considered noble, but doctors were, and probably to a degree they still are. But there's definitely been like a disillusionment with the medical profession over the last maybe 10 or 20 years, and especially since the pandemic.
With that said, you can't blame people for the saying every man for himself, or you not
Yeah,
wanting to publish and take on big pharma. Like you really, it's a losing battle,
it's a
and
losing
you
battle.
can't blame people for wanting to stick their head in the sand and just not getting involved.
Yeah, I mean, if you're by yourself, you basically like you're doomed if you do something like that. So that's what I said. The only way this gets delivered to the general public is if it's a grassroots movement. In other words, I don't want to publish something in a journal because that's me waving a red, like, I don't know, like a big red sign over my head says, "Hey, I'm challenging you right here officially." Right? If it's published, they're gonna go after the journal and the article and me and whatnot. When it's just a blog or something posted on Twitter, it's some guy rambling, and I like it that way. Let's keep it that way. The people, my message really is to the people that are desperate and want to try something else, right?
mm.
So maybe they can look at what I've done so far and maybe try it for themselves. And if it works for them, and I already have emails from actual oncologists saying they cured a few patients with that, I want the oncologist to go public or the patients to go public and say, hey, this works. And in fact, I don't even want them to mention my name, okay? Because that still draws a lot of attention to me, and I don't want the attention. I already, the joy of doing this is enough of a reward for me. Like, again, the only way this becomes successful is if 100 oncologists and 1,000 patients goes online and says, I tried this and it worked. And that's the only way it cannot be stopped. And another reason why I'm doing this with generic compounds is precisely that. If I was using, I mean, there's some other chemicals that can probably, be, even more effective than what I'm using in these cancer studies. I don't want to use them because they're synthetic, they're patentable, they can easily be withdrawn from the market, they're not widely available. You go to any country in the world, you'll be able to find vitamin B1, B3, B7, and aspirin. And it's very hard to stop these substances from circulation. So
Didn't,
that's, yeah.
sorry, Georgie, didn't, speaking of patents, didn't Pfizer patent red light therapy and methylene
And then
blue
blue,
as a
yes.
treatment for cancer?
Yeah, I don't know how this can be done. There was because I when I was still doing my startups in the technology sector back in 2009 2010, I wanted to patent an algorithm, and then my lawyers went to the USPTO and they said, "Oh no, we're moving away from patenting processes. The only way you can patent something is if you show a material change. In other words, if you create a new molecule." Then you can patent that one, but you cannot patent a process. So the only, I mean, it's really not a surprise, but it really speaks to the corruption of the system that they allowed Pfizer to patent a process using completely generic ingredients. There was no material change there. All they say is that we're going to take this generic thing, and we're going to use it for cancer. But it's already published that it's being usable for cancer. So it's already prior work. So, I mean, I won't say that there's corruption there, but Pfizer has a lot of clout, and the fact that this patent was allowed to go forward speaks a lot about what the pharmaceutical companies can do if they wanted to. They can go and basically go against the law and get it their way because the law says, and I read it, there is a law that says there needs to be a material change. Otherwise, the patent is invalid because you're not contributing anything, right? Ideas are cheap or free. You really need to create material change in matter. And Pfizer did not. They actually went and cited the other studies that were using red light and methylene blue to inactivate viruses, bacteria, fungi, and even cancer. And they said, well, we're going to focus solely on cancer. And they started quoting some of the studies that used it for cancer. And Pfizer said, going forward, this is our method. And the USPTO says so. So yeah, that's the system we live in. So I'm not interested in patenting. I'm not interested in publishing. I'm just interested in sharing findings. That's all.
You when you said they're not interested in the law, they are the law. They are the law
They
now.
are the law.
You
Exactly. They
remember,
are the
Georgie,
law.
you probably will remember this, Alannah. I don't know if you will. George, you remember the Prodigy, the band back in
Of
your
course, I remember Prodigies. Fire
yeah,
starter. I'm a fire
remember
starter.
their song? They had a song saying "Our Law," and that's just in my head. The Big Pharma have their own law. They are the law now.
Yeah, they're above the law. The law is only for us, and I've come to realize this. And if you look at politics and a lot of things that are happening lately, it's not just big pharma. There's a certain amount of money and influence beyond which you're untouchable. They'll find a way to, either drop the lawsuit, pay off the accusers, or do something, and they'll get us scot free. There'll be nothing on their record. And for the rest of us, there was I forgot it was like I think it was Supreme Court justice who before he became a Supreme Court he said the average Westerner, maybe specifically American, commits 3 felonies a day. So the only reason we are free is because the government has chosen not to go after us. How many people have the money to defend against 3 felonies daily? Daily, not many. So the government really wanted to come after. No, they're going to go after every single one. But if they want to come after a single person, let's say me, they'll find 3 felonies, right? I don't know. Maybe a park illegally somewhere where it's like a hospital area. I mean, they'll do something. They'll find something. They'll find somebody who will claim that I harmed them with my advice. I'm sure that there will be people that will be willing to claim that for money. And in fact, they're allowed to be paid as paid witnesses. To me, that's corruption and bribery. But the law says, "Who are you, Georgie? Are you a lawyer?" Bribery is whatever we say it is. So it's better that we don't ever get involved with them.
Again, sticking your head in the sand, every man for himself. So, Georgie, we've still got a bit of time if you don't mind. I've got
Sure.
some other questions because I asked Keith and Alannah this at the end of our conversation the other day. It basically was if you or one of your loved ones did get a diagnosis of cancer, whatever form of cancer, what would you do immediately? Like, what action would you take?
Aspirin will be one big thing. Vitamin D is another one. There was a few famous studies from coming out of Japan, and of course they got attacked. They got some of them got retracted, but some of them stayed. So if you go on Google and type G as in George, C as in Charlie, dash, M as in Mary, A as in Apple, F as in Frank. So GC-MAF is another name for the vitamin D carrier protein, and these researchers got amazing results injecting this protein preformed as an injection. You cannot ingest it because it will get degraded by the stomach acid, but you can inject it. And they got full cures of like 20 different lethal cancers, all of them human, but they were in animal trials. And I think they had a few terminal cases in humans where these people recovered from the injections. So this thing was, they got devastated. So a very good example of what happens when you go against big pharma. They published in very reputable journals. I think one of the studies was in Nature. The other one is like in one of the top science journals. And both of these studies got retracted. These researchers got kicked out of their positions in the Japanese universities. I don't know if they're still alive, but the Wikipedia page is still there. And instead of doing GC-MAF, you can just take vitamin D. Because when you take vitamin D, your body will increase the endogenous production of this protein because that's the protein that takes the vitamin D and carries it to the tissues. And in corroboration of that, there are multiple studies demonstrating that people who go from deficiency levels of vitamin D, it usually happens when they're diagnosed with cancer. In fact, the vast majority of cancer patients newly diagnosed have vitamin D deficiency. And if they correct this deficiency back into the normal range, almost none of them dies from cancer with or without treatment. So that's, I think, it's a corroboration to the Japanese findings. And there's some very specific case studies. There is one with terminal pancreatic cancer where the patient started taking, that's a very kind of hefty dose, but she was desperate, obviously. She started taking 50,000 units daily and she was cured. This is published, still not retracted. If you go on Google and type vitamin D terminal pancreatic cancer, you'll get this case study. And another thing that I will do, if you can get your hands on it, I mean, you can do progesterone and pregnenolone. These are always helpful. They have systemic anti-inflammatory effects. But one that has a very, very peculiar and strong anti-cancer effect, which probably means they will disappear from the market, is the abortion pill, mifepristone. Multiple case studies already published with just 100 milligrams of this thing, which is very similar in effects to progesterone. It blocks both the cortisol receptor and the progesterone receptor, but it's mostly a cortisol antagonist. Basically cured terminal pancreatic, breast cancer, liver cancer, colon cancer. So if you can get this, it's a prescription drug, but it may not be a bad idea to take maybe 100 milligrams. And if you cannot get that, maybe a couple hundred milligrams of progesterone. So aspirin, vitamin D, progesterone, and then basically there were several studies that I showed that show that cyproheptadine, which is serotonin antagonist, not just that, but in general, serotonin antagonist stop the progression of cancer. Conversely, serotonin is required for the progression of cancer. So doing things to lower serotonin. And since 90% of serotonin is...
Didn't you post something on your blog in the same aspect
Yes.
of separate? It was Benadryl over 2 weeks.
Oh no, it was cyproheptadine liver cancer. Terminal liver cancer was completely cured. Monotherapy. Person got nothing else. And they were about to get sent home on palliative therapy. In other words, they're ready to die. They usually give them morphine, right? So this person started taking 12 milligrams of cyproheptadine, which is not that high of a dose. It usually comes in 4 milligram pills, and if you have severe allergies, because it's really its original designation was an allergy drug, they only subsequently found that it also blocks the serotonin receptors. So 12 milligrams will be a normal dose for an adult for allergies. They usually take a 4 milligram pill Monday, in the morning, midday, and then like in the evening or the afternoon. So just doing that for 2 weeks completely disappeared not only the primary tumor, but all of the distant metastasis too, which shows you that it's a systemic effect, right? And that serotonin really has a systemic cancer promoting effect. And there are separate studies showing that it's a required thing for cancer development. In other words, if you get rid of serotonin, tumor may not disappear, but it will not grow.
Yeah.
So really what this means is that you should be keeping serotonin as low as possible. And since 90% of it comes from the gut, which means keeping gastrointestinal regularity as high as possible, which means eating insoluble fiber, eating easily digestible foods that do not feed the bacteria that is there, right? Potentially maybe taking some antibiotics if it's a severe case of dysbiosis. But for the vast cases of people that I've met, carrot shell, which is high in insoluble fiber, and or some charcoal, usually does the trick. So really keeping digestion as clean as free as possible, and then keeping inflammation down, and then blocking the stress reaction, which is mostly driven by cortisol. So things like progesterone, which is a over-the-counter more or less cortisol antagonist, or RU486, the mifepristone, which is a prescription cortisol antagonist, really will be the main, my main choices of therapy, and vitamin D.
We spoke about bicarbonate of soda recently over the last few
Yes,
weeks.
yes.
My client, her cell growth, and there could have been other variables at play, but her cells kept growing and growing on her CT scans. And she brought in the bicarbonate of soda daily,
Mhm.
and now they're stable. And we're hoping on the next CT scan, we see regression. Now, she is also doing a good B complex from Thorn Research, and she's also doing aspirin as
Mhm.
well. And then obviously I'm taking care of the nutrition, the sleep, all it. And even one thing I'd love your opinion on is molecular hydrogen. What do you think about molecular hydrogen? Because she's been doing it now for a while. She took a break, and when she took a break, everything started going haywire again.
Well,
Um,
I think it's a valid approach. I mean, cancer patients have a very high level of lipid peroxidation. If you measure the levels of something called malondialdehyde in the blood, it's through the roof. And that's what happens when you basically have mostly polyunsaturated fats in your body, because those are the ones that can generate these aldehydes. By the way, malondialdehyde is a direct carcinogen itself. There's something else called 4-hydroxynonenal, which is another product of PUFA, also toxic aldehyde, implicated in many conditions, including cancer. But the way really to keep these aldehydes from happening is to prevent the peroxidation process. So either you take an antioxidant like vitamin E or molecular hydrogen, which is what prevents this peroxidation process from happening. So molecular hydrogen is literally basically taking the, I don't know, the gas version of vitamin E. It has the exact same antioxidant effect against the polyunsaturated fats. So I'm in favor of it. But it's just that one of the approaches to cancer. By itself, it's probably not going to be enough, because you can keep the lipids from peroxidizing, but it's not going to keep it from being used as a fuel. And really, the goal in cancer should be, because cancer truly is a state of extreme diabetes, and we know diabetes is driven by overoxidation of fatty acids and wasting of glucose. In fact, you can look at type 2 diabetes as a form of mild, non-proliferating cancer, but it's the exact same metabolism. The extreme form of it, which is diabetes type 1, if left untreated, it has the exact same wasting characteristics, in other words, cachexia, as cancer. In fact, these people will die very quickly unless you give them insulin. What does insulin do? It restricts lipolysis, inhibits the oxidation of fatty acids, promotes the uptake of glucose, and promotes its oxidation. So, and unsurprisingly, believe it or not, there's already clinics in Switzerland, many other places, that are starting to do high dose insulin therapy for cancer. If you type insulin therapy for cancer, you'll see plenty of studies, legit, right? And there are now clinics doing that. So, hydrogen very good to prevent the damage that the direct carcinogenic damage that peroxidation products of PUFA can do, but by itself it's not enough. It's just one of multiple tools that need to be used.
I had Dr. Tyler LeBaron. You're probably aware of him on the podcast about a month ago. So he's the founder of the Molecular Hydrogen Institute.
Mhm.
He literally is one of the leaders in molecular hydrogen research in the world. But he was discussing, well, we know that molecular hydrogen is a potent anti-inflammatory in itself and
Yeah.
being selective free radical scavenger, but also he said that they have solid research showing molecular hydrogen improving metabolic syndrome, including fatty liver reversal.
Yeah.
That in itself is solid grounds for what you're saying as well.
Most of the conditions, the chronic conditions that we discussed, if you look at them, every single one of them has a component, two components at least. Chronic inflammation, number one, or lipid peroxidation, number two. And in the case of PUFA, they go hand in hand, because PUFA is not only the only fat that can be peroxidized, it's also the only source for production of the inflammatory mediators, which is the prostaglandins and the leukotrienes. So really a case for not eating PUFA at all. That should be really, if you can do that, or eat as little PUFA as possible, that'll be the best. Unfortunately, because when you eat a mixture of fats, the saturated fatty acids are more easily oxidizable, so the majority of them will get probably oxidized, and after that the monounsaturated fats. The polyunsaturated fats gets mostly stored, which means that if you're actually under stress, the dominant component of the fatty acids in your bloodstream, because it's coming from your fatty tissue, will be PUFA. And that's why really when you're under stress, you get a massive increase in peroxidation in these like reactive oxygen species, and also inflammation, because this oversupply of PUFA serves as the raw material for creating the prostaglandins and the leukotrienes. So if you have a lot of stored fat, you should try to avoid stress, because you're literally giving yourself a pro-cancer injection every time you increase lipolysis in your body. And I think that's one of the reasons we're seeing that the people over a certain age, when they get a significant amount of visceral fat, they don't benefit from exercise. In fact, they may often get worse. And then really the way you should be treating obesity in these people is through endocrine methods. In other words, increase the oxidation of this fat without releasing it into the bloodstream. Diabetes type 1 recently was discovered to be due to damage of the beta cells in the pancreas produced exclusively by circulating free fatty acids. Kidney damage in diabetes has already been demonstrated to be due exclusively to the damage done by elevated free fatty acids. So free fatty acids in the blood beyond a certain level are toxic. Cells don't like them, right? Because they can freely diffuse, and if they overaccumulate, they can really poison the entire cellular machinery, even if they're not peroxidized. But in the case of PUFA, a good portion of them will be peroxidized, and then the damage is increased multifold. So yeah, molecular hydrogen a great tool, but because it addresses the lipid peroxidation byproduct, which addresses part of the inflammation, right? But then there's another part of inflammation, which is, I want to call it endocrine. It's not so much the driven by lipid peroxidation in PUFA. It's the endotoxin one. And the endotoxin one, when we're under stress, as I mentioned, cortisol upregulates our sensitivity to endotoxin by increasing the endotoxin receptor, TLR4. So we really don't want to be under chronic stress. And it's surprising to me that doctors argue that stress only kills if it's acute, right? Or it only causes damage if it's strong, it's very, very intense and acute. When in basic research, there is something called CUMS, chronic unpredictable mild stress. It's an established way to cause not only depression and every mental condition that psychiatry investigates, but also almost every chronic condition in animal models. So if we know that chronic unpredictable mild stress, I emphasize mild, but it's uninterrupted, can cause every other single condition that we know in men, why would it not apply to humans? Well, the answer so far that it begins like, well, Georgi, until it's proven in humans, it remains an issue for rodents only. And I said, don't tell me that all these researchers have this like incredible, I don't know what should I call it, noble idea to study rodents for rodents' sake. I mean, it's clearly they're doing this because they think there's some kind of implication for humans, aren't they? Or are you telling me we're giving out PhDs in rodent biology just for the sake of rodent biology, and it has no relevance to us?
Yeah, rodents matter too, Georgi.
I know they do. There's a statue of a rodent in front of the NIH that they recently built in honor of all of the experimental animals and how much they've done for medicine and for humanity. So if that's the case,
yes. Thank you for your sacrifice. So I suppose I'll start to wrap up now. But what you alluded to a minute ago was a lot of people in this scenario, they really should be reducing fat and focusing more on glucose oxidation, which is contrary to what most bloody people are doing nowadays and anyway. And even, I mean, you said if you can eliminate PUFAs as much as possible, that's quite a challenge, as we both know. Yeah. Most people in general just have a challenge, because I do a lot of macro tracking as well to help bring awareness to people of what they're actually eating. Most people don't know unless you get them to track. To even get any fat down is a big challenge for most people.
I mean, it's everywhere. It's so cheap to produce because it's coming from seed oils, and all of these cultures are heavily subsidized in all countries that are producing them. Corn, soybean, sunflower, right? If you're in the States, corn and soybean are heavily subsidized. If you're in Europe, usually sunflower or some other seed that's producing an oil is subsidized. So the production of seed oils, which are predominantly omega-6 fatty acids rich, is very cheap. So you're going to find this as a source of calories, because to medicine, a calorie is a calorie is a calorie. But as we know from bioenergetics and multiple, in fact, over 100 years of published research, a calorie from a carbohydrate is not going to cause the same physiological reaction compared to a calorie from fat and a calorie from protein. They're very difficult. They have very different physiological effects on the body, and different effects on the redox balance, and different effects on the overall health. I mean, if it was that easy, right, we could fully replace all of our carbohydrates with fat. And there is a movement that does this. It's called the paleo diet, or like the low carb diet, or in the intermittent fasting, which is also like a form of low carb because you're not ingesting any carbs. And it was very popular for a while. I was a low carb myself in 2009, gave myself very serious health problems. Thankfully, I stopped. But now more and more studies are coming out showing that low carbing, while initially helps you lose a little bit of weight, almost all of the weight you've lost is water, and it only persists for about 2 weeks. If you push it beyond that, you start losing a lot more muscle than you're losing fat. And one of the reasons is that fatty tissue is a lot less innervated and a lot less blood supply than muscle tissue. So basically, when you're under stress and when you get the elevation of the stress hormones, like adrenaline, which shreds your fatty tissue, and cortisol, which shreds connective tissue, muscle, and bone, the latter will get a lot more damage than the fat because there's simply not enough signal getting to the fat to get shredded as much as the other ones. And this is a great, I think one of the greatest confirmations of that was the Biggest Loser show, where basically they got these like morbidly obese people to lose almost all of their excess weight by doing grueling regimens of like exhaustive exercise and starvation, like fasting for days. And the ones that, the biggest losers eventually got an award. And I said, what an aptly named show. As soon as these people stopped the competition, not only they rapidly regained all of the weight that they lost, they regained it while eating about half of the calories that they used to eat before. What does that tell you? That their metabolic rate tanked by about 50%. And worse still, it looked like, yes, they did lose a lot of weight in absolute terms, but most of the weight that they lost was actually muscle and bone and connective tissue. So they got this horrible looking droopy faces, which is now what we're seeing on the drugs Ozempic and other similar drugs, because you're losing mostly muscle and connective tissue. That's terrible because that's the tissue that determines your resting metabolic rate. It's much more metabolically active than fatty tissue. So the Biggest Loser people ended up regaining the weight, and they became the term is skinny fat, is what we call colloquially. In medical terms, it's known as sarcopenic obesity. In other words, no muscle, only fat. And now they're in really bad situation because they're worse than they started before. Their metabolic rates are lower. They're constantly hungry because they cannot even half of the calories that they used to eat before. So they really became the biggest losers. And I feel bad for them because they got tricked by the doctors that were asked to act as consultants for the show, who thought that it's a good idea to take middle-aged people and basically ask them to exercise and starve themselves to death, or almost to death. So now these people are basically living zombies. They feel absolutely terrible, and they don't know how to recover their health. So we should not be stressing ourselves out because it's really contributing to not only tanking our metabolic rate, but also increasing the chronic inflammation in the long run, which is what I mentioned the very beginning of the show. It's really not a good way to lose weight.
This is my concern because for where I live, I do have a lot of clients, and the Ozempic, the Wegovy, the semaglutide, it's huge now. It's here locally around Calgary, huge. And my concern really is the changing of the metabolic rate, how it's affecting the thyroid, body fat set point, and then not even to mention all the other issues because not all doctors are doing it correct. So some of them maybe, but most not doing it correct.
Did you see my recent blog post? I have like 2 or 3. So some of the already concerning issues, they can cause gastroparesis. Now, if you do that, it could be permanent. So I don't know what you do in the situation other than you can die from gastroparesis. In other words, your digestive system stops working completely. It's paralyzed. The other thing that it causes is permanent blindness, right? So these issues are rare, and a lot of people will risk, let's say, 0.5% risk of. Sorry about this, like the light went up.
And I actually have to run to a meeting real quick. But it was so good.
Thank you, Alannah, for joining
I'll let you guys. This is such an important topic, so I'll let you guys handle it. But good seeing you, Georgi.
Thanks, Alannah. See you soon.
I'll talk to you guys soon.
Thanks.
Bye.
So a lot of people will accept the risk of, let's say, 0.5% on average of getting gastroparesis or blindness if they're going to lose a lot of their excess weight. It's really a very debilitating condition. But recently, another study came out that showed that 40% of the weight lost from the drugs is muscle, at least 40%. And that's an absolutely horrible, horrible outcome, because then you end up looking at the people in the Biggest Loser show, and in fact, there's already a term called the Ozempic face. Have you seen it on Google?
Yeah, yeah.
So a lot of famous actors, so the facial skin starts drooping, and the reason is that because a lot of which tells me that the drug probably promotes cortisol somehow, because they're losing connective tissue and muscle in the facial muscles, so the skin really starts sagging. So yes, they would lose the excess weight, but they look like they aged by about 20 years or even more. So I don't know if that's to me that's an absolutely terrible outcome, and it's not a rare outcome like the gastroparesis or or the blindness. It's actually the main mechanism of the action of the drug results in about more than 40% of the weight loss that every single person taking that will experience will be muscle loss, and that's terrible outcome, and that's for in everybody who's using the drugs.
So they're losing the weight, but at what cost? And
Exactly.
well, you know what's not rare. So the gastroparesis may be rare, but we could probably debate that now. But you know what's not rare is that nearly everyone does experience some sort of stomach issue, whether or not it's increased acid reflux or SIBO or chronic diarrhea, because you can't digest, you're just flushing all the time. I would argue everyone experiences something, even if they don't recognize, oh, it really is at what cost. And even if they are going catabolic, losing 40% of muscle, like me and you both know, realistically, these people who even come off Ozempic and they're put in this position, how many of them are going to go then and hit the gym and start prioritizing muscle growth?
They won't. Most of them will not.
Because they wouldn't be there in the first place if they
Exactly.
weren't looking for a quick way out.
Yeah, I agree, and I think that's kind of like the nefarious purpose of the big pharma is that these people will be hooked on these drugs for life, even if not continuously, periodically. So let's say they do like Ozempic for a couple of months, they drop the weight, they stop the Ozempic, they go around, start partying, then they get the regain the weight, then they go do Ozempic as well. But eventually, I think, I mean, because of that muscle loss, if it's at least 40% muscle loss, I think we're going to start seeing some terrible outcomes. I mean, if the metabolic rate tanks, at some point, these people will start gaining massive weight on an absolutely abysmal amount of calories, abysmally low. And that will probably trigger some kind of lawsuit, because they'll say, okay, if I cannot even have like a breakfast, and let's say I only eat breakfast and I don't eat anything else, and I'm still ballooning, something is terribly wrong, and this drug caused it. And it'll be right. The drug caused it because they lost all their muscle mass, right? But also the long-term decline of the metabolic rate will probably trigger a lot of chronic conditions that we know now are all due to lower metabolic rate, especially the ones that even medicine recognizes are metabolic, such as type 2 diabetes, type 1 diabetes, potentially cardiovascular disease, right? So, I think there'll be class action lawsuits in the future. If I was an investor, I would say short the stock of the companies that are producing these drugs, because 5 to 10 years down the road, there will be massive lawsuits, maybe even earlier. But for now, it's a fad. Everybody wants to be skinny, right? But unfortunately, doctors don't recognize the difference between like a good weight loss and a bad weight loss. So let's say a bodybuilder walks into a doctor's office. Aside from the fact that this person is usually taking steroids, they're actually pretty healthy, probably healthier than most of the patients there. Even though their BMI will be through the roof. They may have a BMI of 40. So they'll be morbidly obese according to the BMI statistics, but most of their weight will be in the form of muscle, which is actually really, really good. The doctor will probably look at them and say, well, according to the BMI, I need to put you on a diet, but I can see you're not fat, you're just bulky, right? So they'll probably let them go. But what I'm trying to say is that, most doctors will not actually look at that. They'll say if your BMI is above a certain point, you need to lose weight, period. And they don't care if you're losing muscle or fat or bone. To them, it's all weight loss. It's all a good thing. And it's not. It's not. You want to be losing fat. You do not want to be losing muscle tissue, connective tissue, and bone. These things are absolutely vital, and you don't want to lose them. So the way you really lose weight, and how it was done in the early 20th century, which tells you how much medicine has declined since then, because apparently doctors in the early 20th century knew how this should be done, is by raising the metabolic rate. So they were using a drug called dinitrophenol, abbreviated to DNP.
Yeah.
And what it really does is it raises your metabolic rate by 40 to 50% without you doing anything, right? So obviously temperature will increase, you're going to start sweating and whatnot. So unfortunately, if you overdo it because it raises your body temperature, eventually you might die of a heat stroke. But it was only seen in a very few cases out of hundreds of thousands using it. and they really overdid it. And in fact, the suspicion that all these people were actually attempting suicide. But the unfortunate result of those activities in the 1920s and 30s is that the FDA banned the drug, right? But it's still the finding remains that the people who used it successfully and lost the weight successfully, they remained healthy. They did not regain the weight. They even led to a change in their their social preference, in their eating habits, in their exercise habits, and that's really the way to lose weight, not through stress, right? And a confirmation of that is that if you look at elite athletes, they almost never diet. They almost never fast. I mean, by dieting, I mean they're very mindful of their diet, but they almost never fast. They almost never cut calories. So if they have to lose weight, these days they use either T3, which is the active thyroid hormone, or they use anabolic steroids, probably the most common form, or they use dinitrophenol, or a combination of the three. The fact of the matter remains, really elite athletes do not fast and do not overexert themselves. They're very mindful of their body. They're very mindful of their diet. They know what stress can do to your body, and they know that chronically overexerting yourself is a recipe for an absolute disaster.
So you have to increase metabolism,
Yes.
but it's not uncommon for me to speak to a woman where her daily calorie intake is 700 or 900 calories a day, and she's still gaining.
Yes,
And
very low metabolic rate.
I'm trying to explain, we can't cut your calories anymore. We bring you to 500, you lose weight, you plateau. Where do we go till we're at 0? And people don't get this. So then it is a case of now you have to do even more work to recover than you would have had to do in the first place.
Yeah.
And it's quite a challenge. I mean, if I was just looking at the financial aspect, Georgie, I'd be saying, yeah, do Ozempic, because you're going to come to me pretty soon for help.
Exactly. You're going to have a lot of clients soon, whether you want it or not. They're coming because the biggest loser show was just 20 or 30 people. Now we have tens of millions of people, or even hundreds of millions of people around the world using Ozempic. Very soon there'll be a situation where they have to make a choice. Either continue taking Ozempic for life, or at least periodically, but indefinitely, or go back to something else that's not drug related, but the only real other thing that really is good for them is recover metabolism. And it can only happen through like a dietary regimen plus potentially taking thyroid and maybe like a aspirin, which is also a metabolic stimulator, caffeine, progesterone, yeah, DHEA also a metabolic stimulator, and of course DNP, which is like so dinitrophenol was reserved back in the day for really morbid obese cases where they were not amenable to any other therapy. But even back then, doctors knew not to tell the patients to starve, to fast, because they knew that they will lose the weight, but at the end of that period, let's say that person was eating 12,000 calories a day, got morbidly obese. But if they go back to let's say to 1,000 calorie a day diet, right, and they stay on it until they lose all of the extra weight, by the end of it, let's say they're now skinny, they say, okay, I want to feel normal, I want to eat normal again. No, unfortunately, 1,000 calories a day is your new diet. You go anywhere above that, because now your metabolic rate is actually adjusted to 1,000 calories a day. You go anywhere above that, all of that extra will end up stored as fat. And little by little, you will regain the weight. And it ends up being not little by little, because if a person is being, let's say, a couple of weeks or even months of like 1,000 calorie diet, they're starving. Like, it's not a pleasant environment. You're cold, you're trembling, you have you have brain fog, you're fatigued. So you want to go back to a normal diet. But then you tell them, well, not only you cannot go back, you have to stay on 1,000 calorie diet for life. Obviously, all of them are going to violate that. They're probably going to start eating 3 or 4 calories. But if the metabolic rate is now at 1,000 calories, just 3 or 4,000 extra calories a day means absolutely massive difference. They're going to pile the weight back on, probably half the time it took them to lose it, if not even less. And by the way, the weight that they will pile back on will be almost purely fat, while the weight that they were losing was mostly muscle. So they're going to end up with a worse ratio of fat-free mass to total mass than they were when they started. Really a bad situation. I mean, the only way out of it, I was reading, there was an animal study that I posted on the Rapid Forum 4 or 5 years ago, showed that when obese rats or mice are made to lose weight on a combination of fasting and exhaustive exercise, they got into such a hypercortisol state that when they stopped doing these things, their skyrocketing cortisol did not decline. Yeah. So cortisol started upregulating its own production, and that's something I forgot to mention during the cancer discussion. Not only cortisol upregulates the enzymes for inflammation, Cortisol upregulates the enzymes responsible for its own production. So while you're exerting yourself and you're raising cortisol, cortisol has a sort of like a self-sustaining vicious cycle mechanism. And when you stop stressing yourself, cortisol will stay elevated. And that's exactly what they found in these formerly obese rodents. And after they lost all the weight, they saw that they had really high cortisol, so they separated them into two groups. One group went back on a normal calorie diet, right? And the other group got an anti-cortisol drug, mifepristone. The group that went back to the normal diet experienced the exact same thing as the participants in the Biggest Loser show. They ballooned and overshot their original weight by I think like 30 or 40%. So they became more obese on fewer calories than they were when they started. Only the group that got the anti-cortisol drug managed to normalize and keep the excess weight off and recover the metabolic rate, not to a healthy level. They still couldn't recover to a healthy level, but it was like somewhere in between. Yeah. So in other words, if you really do, if you really end up overexerting yourself and fasting at the same time, you can really damage yourself endocrinologically and end up in a situation where you're gonna have to have like a prescription medication or like taking other anti-cortisol remedies like progesterone or Imodium or even aspirin in order to normalize. Because if you rely only on the diet and like and lack of stress, you will not reset back to a lower stress mode. Cortisol will actually permanently like upregulate itself, and it will stay there until something makes it go back down to a normal level. And unfortunately, that's something will have to be like an intervention with a supplement, or steroid like progesterone, or mifepristone, but I don't mention it because it's a prescription that most people don't have access to it.
Okay, very, very last question. Very last question, because I need you to try appease the people who have been scared away from aspirin because of stomach bleeding. So they're almost doing them a disservice.
I can send you the 2 articles I posted back, I think it was as early as 2015 or 16. Aspirin has really notorious, is notorious for being risky for causing both brain bleeds and stomach bleeds. And doctors scare away the patient, saying like, if you take aspirin, you can get a hemorrhaging stroke. It can kill you much faster than a normal stroke would, or you can do a GI bleeding, and that can also kill you pretty quickly. Do not take aspirin. Well, 2 human studies demonstrated, well, actually 3 studies. One found that the fear mongering about the aspirin bleeding is grossly exaggerated. The actual percentage of people who get these bleeding events is much lower than what's been reported. The study did a review of all the studies ever published and found out that the reason we're getting this idea that aspirin is dangerous for us is that a few studies were published in the very reputable journals by pharma companies, and they're getting all the attention. But if you look at all of the studies available, actually the risk of aspirin causing bleeding is very low. Not only that, but even though aspirin may have a slightly increase the risk of bleeding in either the brain or the stomach, ironically, people who took aspirin were at a much lower risk of dying from a major bleeding event when admitted to the hospital. And specifically, they were at much lower risk of dying from brain bleeding or stomach bleeding, which are the exact things that aspirin should be increasing the risk of, like, for actually happening. So while it may slightly, not nearly as much as what media will tell you, while it may slightly increase the risk of bleeding, it actually protects you from dying from major bleeding events. Really, the opposite of what mainstream media is telling you.
And then we spoke about the combination of glycine there, and
yes.
We looked at
or baking soda,
yeah.
or a little bit of vitamin K. I mean, how difficult it is to get just like even the cheapest form of vitamin K that's out there, and just take, like, whenever you take aspirin, take like a drop if it's liquid form of vitamin K, or if you don't have to take aspirin every day. Recent studies show that if you take just twice a week a tablet of aspirin, it's sufficient to have the exact same cancer preventing and heart disease preventing effect that if you took it every day. So if it's for prevention purposes, you can take it twice a week, which will lower the risk of bleeding because you're not taking it every day. And just on those 2 days, just take a little bit of vitamin K or a spoon of gelatin, or mix it with baking soda and drink it. All of these decrease the risk of the aspirin causing the bleeding.
Brilliant, Georgi. My mind needs a vacation now. Thank you for your time.
I'll send you the articles specifically on aspirin, the risk of bleeding risk being overblown, and the fact that it actually protects from dying from major bleeding events.
Yeah, send them to me. As you know, I will remind you, I am a pest, not just to you.
I'm going to go home. I'm going to go home and send them right now. I don't want to have something like in the back of my mind saying that.
Well, thanks, Georgi. This has been great. I will, of course, send everything to you when it's up.
Thank you. Appreciate it. Thanks for inviting me again.